Good afternoon, everyone. Welcome to the Yale Sleep Medicine Grand Rounds. My name is Ritika Thapa. I'm one of the pulmonary critical care and sleep medicine faculties here at Yale. Just some brief announcements before I introduce today's speaker. Please make sure that you're muted. In order to receive the CME credit for attendance, please see the chat room for instructions. You need to sign up to get this credit. If you've not signed up already, please send a message to Debbie Lovejoy. If you have any questions or comments during the presentation, please use the chat room or you can unmute yourself at the end and I will also moderate the session. Recorded versions of these lectures will be available on YouTube a few weeks after the presentation. And today I have the honor of introducing Dr. Aesha Jobanputra. She received her medical degree from Rutgers, New Jersey Medical School, where she also completed her internal medicine residency. She then did her pulmonary and critical care fellowship at Rutgers Robert Wood Johnson University Hospital, followed by a sleep medicine fellowship at University of Penn. And then she came back to New Jersey again, where she's currently an associate professor of medicine at Rutgers Robert Wood Johnson Medical School and is also the director of the sleep lab there. Her interest has primarily focused on sleep disordered breathing, sleep and fatigue mitigation, and sleep issues in special populations such as cystic fibrosis and post-COVID. She's lectured on sleep disorders nationally and is actively involved in various educational activities as well. Dr. Jobanputra has received multiple honors, including Years of Service Award from AASM this year. She's also authored numerous peer-reviewed articles, book chapters, and abstracts. She's held leadership roles in professional societies, including committees and leadership appointments with the ATS, AASM, and currently serves in leadership roles in the New Jersey Thoracic Society. Thank you so much for being with us, Aisha. And without further delay, I would like to hand it over to you to share your expertise on training while tired, the cost of sleep deprivation in trainees.
Thank you so much for that kind introduction. I feel like an imposter with that introduction. So I will get started and I have no financial disclosures. I always wish I did. I want something to put there. If anyone has connections, please reach out to me. And today, when we think about training, we often think about learning curves, competency milestones, and patient care. But one of the biggest influences on all of those things is something we don't talk about as often, which is sleep. So over the next hour, I really want us to reflect on what happens when sleep is restricted or disrupted. And we'll explore how that fatigue shows up in our decisions and what we can do about it. So I'll start by painting a picture of what sleep deprivation and restriction does to our neurocognitive function. Then we'll zoom in on how this plays out specifically in medical training, where long shifts, night float, and call schedules can sometimes blur the lines between, what we consider true dedication and danger. And finally, I want to shift from awareness into action, talk about some of the practical steps we can recommend to our trainees to manage fatigue and protect both the performance and also well-being of our trainees. So as we go through this, think about your own experiences, the nights you might have powered through on those long shifts, the times your judgment felt clouded, and when you noticed fatigue in a colleague, because the goal here isn't just to know more about sleep. You guys are much smarter than I am and know much more, but it's really to reshape how we can think about it in the culture of training. So I wanted to start off with this roadmap for today's discussion. So we'll start with a quick introduction to basic sleep and circadian physiology, as I understand there might be some trainees and medical students attending today. Then we'll move into how the interest in fatigue and sleep amongst trainee began. And I know this is not a new problem, but that's kind of the one that's come into focus over the past several decades. And then from there, we'll examine the consequences of sleep deprivation and restriction and how it impacts neurocognitive function. Then we'll connect that to the importance of sleep specifically for trainees and what is at stake when our trainees are feeling tired or fatigued while working. And finally, we'll wrap up with some strategies for sleep and fatigue mitigation, some practical approaches we can use both individually when we're talking to our trainees and also maybe at the program level to kind of promote safer and more sustainable training. And so this arrow that I have there really reflects a progression from understanding the science to recognizing the problem and then acting on some of these issues. And I'll start off with this quote: "Sleep is a basic human need, not a luxury. more sleep or better quality sleep is going to result in clearer thinking and better mood engagement, which will all have a positive effect on patient care. And with that, talking about sleep in a typical adult, it begins with non rapid eye movement, non-REM sleep, with the first episode of REM sleep occurring about 80 minutes or so later. And then NREM and REM sleep both alternate throughout the night in recurring cycles. They produce this characteristic pattern of consolidated night sleep as seen on this hypnogram. And this consolidated sleep architecture is really essential for achieving that full restorative benefits of sleep. And the two main biological processes that regulate sleep are homeostasis and our circadian rhythm. And I do have pictures of my kids throughout the presentation. This is one of him falling asleep while hiking in Iceland, where we did not know if he was breathing, and we were really, really freaked out, but he had just fallen asleep. You know, could not fight it any longer after the time change. So first, the homeostasis, or what we call process S, is our sleep drive. It's really the body's internal pressure to sleep. It builds up the longer we're awake, and it dissipates as we fall asleep. And this process determines how much sleep we need, the sleep quantity, and how restorative it is, based on the sleep quality. So when we're sleep deprived or the sleep quality is very poor, the process S is going to be high. The second is the circadian rhythm, or process C, or what we call wake drive. And this is a body's internal clock. Primarily, it's located in the suprachiasmatic nucleus, and it helps us stay awake during the day and promote sleepiness at night, independent of how long you've been awake for. So this is just a graphic depiction of the two. As you can see, the process C follows this nearly sinusoidal pattern, repeating independently of sleep episodes. It's pretty low during the sleep time, and there is, lack of signal of it at nighttime, allowing us to actually sleep. Whereas process S represents the homeostatic pressure for sleep, seen here in blue, and it increases as long as there is no sleep episode. Now, if there is no sleep episode here, and it continues upward, as you can see in sleep deprivation depicted here in red, the process S will continue to increase as well. If one was to fall asleep, that would decrease. Now, the sleep pressure is the quantification of propensity to fall asleep, and is determined by the difference in the two processes. So ideally, when these two processes are in sync, they allow for rest. But during, shift work, overnight calls, or irregular schedules, they tend to fall out of alignment. And that's when fatigue, impaired performance, and some of the adverse health consequences emerge. Good health is also about when we sleep, in addition to how much we sleep and the quality of sleep. And really, humans are one of the only species that routinely override their biological clock. In our 24/7 society, we're pushing our bodies to stay awake when really should be sleeping, and respecting that. So, chronic circadian disruption and insufficient sleep are both linked to multiple adverse metabolic, cardiovascular, cognitive, and mood outcomes. There is also increase in impaired immune function, heightened pain sensitivity, and actual performance. And overall, there is increased risk of mortality. So again, a lot of issues when there is insufficient sleep and there is misalignment of the our sleep time. So what is fatigue? Fatigue is defined as a condition that's characterized by lessened capacity for work and reduced efficiency of accomplishment, usually accompanied by a feeling of weariness and tiredness. And lack of sleep is a big contributor of fatigue. And AASM recommends greater than 7 hours of sleep for healthy adults. But in 2020, about 33.2% of US adults reported sleeping less than 7 hours per night. And there is a difference between acute sleep deprivation and chronic sleep restrictions. And I'm going to talk about that in a little bit. So now that we've covered the basics of sleep, let's shift gears and talk about why we're so interested in sleep in the context of medical training. So for decades, fatigue was almost considered like badge of honor in medicine. We've all heard, or maybe even said ourselves, a version of this story that back in the good old days, we used to be on Q one call for 97 hours straight, no duty hours, no apps, no phones, no wellness talks, and we walked to the hospital uphill both ways in the snow and through the eye of a tornado. And we still made it to the morning rounds on time. So, there's a certain nostalgia in that, but there's a lot of mythology in that as well. And what's changed isn't that trainees today are what we call softer. It's that we now have decades of evidence showing how chronic sleep restriction and sleep deprivation affect performance, learning, and safety. So, the renewed interest in trainee sleep really comes from a shift from going from glorifying endurance and what we used to call dedication to understanding physiology. And the case that brought national attention to this was, attention to the resident fatigue and to this issue was the Libby Zion case, the 18-year-old Libby Zion. And what happened here is that Libby Zion, who is an 18-year college freshman, was admitted through the ER on March 4th, 1988 to New York Hospital with fever and agitation. She was evaluated by two residents who, after consulting her family physician, they planned to hydrate her and just observe her in the hospital overnight. And when she developed jerking movements, they prescribed her meperidine, unaware that she was already on phenelzine, an MAOI antidepressant. And then overnight, the residents were covering dozens of patients, but Libby became increasingly agitated. The nurses called over the phone. The residents, placed orders for restraints, and haloperidol was ordered as well by phone. And by morning, her temperature had reached 107 degrees Fahrenheit, and she suffered a fatal cardiac arrest. And it was later determined that the drug interaction caused serotonin syndrome, leading to severe hyperthermia, and ultimately her demise. And the case was spotlighted. It basically put large spotlight on resident supervision, the workload, the fatigue, and ultimately catalyzed the duty hour reforms that happened after. And her father, Sidney Zion, who is a lawyer and journalist, was outraged. He, rightfully so, and very sad by the whole situation. He argued that inadequate supervision and the exhaustion that the resident felt led to her demise, his daughter's demise. And the case, of course, received intense media attention, highlighted the grueling work hours of the house staff, and, he ultimately wrote in New York Times op-ed piece that you don't need kindergarten to know that a resident working a 36-hour shift is in no condition to make any kind of judgment call. Forget about life or death. Um, Ultimately, a grand jury investigation found that there was no criminal liability, but identified systemic issues, and there were major issues in supervision and workload. So it's really, Libby Zion case has become a turning point in medical training, bringing attention to what we will be talking about, resident fatigue and its effect on patient safety, the need for structured supervision, accountability, and recognition that the system design, not just individual competences, affect outcomes, patient outcomes. And since then, of course, there have been changes. We have long ways to go, but since then, there have been 80-hour weekly restrictions, 24-hour maximum shifts, allowing 4 hours for rest, and additional paperwork that might need to be completed, one free day per week, and in-house call frequency to no more than 1 in 4. And there is also a statement about fatigue mitigation in ACGME manual that says programs must educate all residents and faculty members in recognition of the signs of fatigue and sleep deprivation, alertness management, and fatigue mitigation process. So what does the evidence actually demonstrate when it comes to the effects of sleep deprivation and restriction? So this was one of the landmark studies done by Donjan and team that looked at, real world effects of chronic sleep restriction and deprivation in 2003. So this was a carefully controlled lab experiment where they enrolled 48 healthy adults and they were randomized to one of several groups. They were either randomized to sleep deprivation groups where the group was not allowed to sleep at all. They were awake the entire time, or they were randomized to 4, 6, or 8 hours of time in bed for 14 consecutive days. And the group that was the sleep deprivation group was awake for 88 hours. Now, if anyone's trying to calculate this in your head or figure out how long that is, it's 3 days and 6 hours. So this group was awake for that long. And throughout the study, the participants were kept on strict schedules. They had the same wake time, controlled lighting, no caffeine, no naps. And in between test bouts, they were allowed to do like passive activities like read, maybe watch television, interact with lab staff to help them stay awake, but no rigorous activities were permitted, such as exercising. And subjects did not use any caffeine, alcohol, tobacco, and or medications in the 2 weeks prior to the experiment. And this was verified via blood and urine screens, as well as questionnaires. Volunteers were also screened to make sure that they had no medical, psychiatric, or sleep-related disorder diagnosis and were drug-free. And they also did not report shift work or night shift working within the past 2 years. They also did not travel across time zones in 3 months prior to enrolling in the study. And for each of these groups, they had multiple tests, multiple testing that was done, including psychomotor vigilance test. They did digit symbol substitution task. Um, to measure their working memory. And then they had serial addition subtraction tasks. And this also measured working memory and attention. There was also Stanford sleepiness scale that was completed to kind of monitor self-rated sleepiness on this 7-point scale. And so first, I really want to focus on the sleep deprivation group. And here I have the two graphs side by side. So here on the x-axis, it mentions days, so the number of days they were awake for. And on the y-axis here, it's your PVT lapses. So how many laps did they have in their psychomotor vigilance test? And here is the Stanford sleepiness scale. And I really only want you to focus on the open squares at this time, which represents the sleep deprivation group. And as you can see, the PVT performance declined steeply and progressively as the subjects were awake for longer and longer period of time. So the more lapses you have, the worse your performance is, right? You're missing that stimulus. You're not pressing the button on time. They also reported equivalent amount of sleepiness. They got more and more sleepy as they were awake for a longer amount of time. This trend was also seen in the other testing. So this is the digit symbol substitution task, and this is the serial addition subtraction test. So their performance worsened in both of these testing as well. And here that's represented by these filled in circles in black at the bottom. Now, let's look at what happens with the sleep restriction group. So I have the complete graph here, and here the filled in circles and the red line represent the group that was restricted to 4 hours in bed. The yellow represents the group that was restricted to 6 hours in bed, and um, the group that was restricted to 8 hours in bed in green. And this was, again, you can see here that the sleep restriction groups over the course of 14 days, which is on the x-axis, for each of these restricted group, the performance also declined steadily. So there is clear dose response effect. So the group that was spending 4 hours in bed did a lot worse with their PVT testing compared to the 6-hour group, compared to the 8-hour in group. And after just 2 weeks of sleeping 6 hours, which is not much, a lot of people sleep 6 hours per group. Even, amongst us, a lot of people sleep 6 hours, but you can see that after just 2 weeks of sleeping for 6 hours a night, the participants were impaired on their reaction time testing as someone who had been awake essentially for 24 hours. sleep deprived for 24 hours. And those limited to 4 hours of sleep performed even worse, and as awful as someone who had been completely sleep deprived. So overall, there is dose response effect present in all of these three cognitive performances, and they separate out pretty evenly with any type of sleep restriction. And the other interesting part was that when you looked at the neurocognitive performance testing, the subjective sleepiness in this group, both of these group, compared to their performance, was never equivalent to those of somebody who was really awake or doing so awfully on their PVT testing. So it really flattened out in the 4 hours per group, and also in the group that was awake, restricted to time in bed for 6 hours per night for 14 nights. And even though their performance was really kind of awful on the PVT testing, they were not feeling sleepy. They were only feeling slightly sleepy compared to this group that was deprived. They were feeling very sleepy at the end of that. So therefore, unlike the performance measures, the sleepiness ratings appears to show adaptation to chronic sleep restriction at the end of those 14 days. And in addition, there is no significant difference in the sleepiness scores between the 4 hour and the 6 hour sleep restriction groups, whereas there's a huge gap in their performance, as you can see here. So once sleep restriction is chronic, subjects either cannot reliably introspect with regard to their actual sleepiness levels, or as long as they're receiving at least approximately 4 hours of sleep per night, they don't experience any sense of sleepiness anywhere near the levels found for total sleep deprivation group. So that's very, very concerning. Like, your brain's not performing well, but you don't actually think that you're that sleepy. Now, this is another landmark study that was done by Belenky and colleagues that was conducted around the same time as the Van Dongen experiment, and it used nearly identical lab conditions to examine how performance kind of degrades during or with chronic sleep restriction and recovers after restoration of sleep. And Belenky and colleagues brought healthy adults into the sleep lab. They assigned them to receive either 3, 5, 7, or 9 hours per night of time in bed. And they ended the experiment with 3 days of recovery where all the subjects were allowed 8 hours of time in bed. And again, there was no caffeine, no naps, no excuses, just endless vigilance testing, dim lighting in the lab. And basically, participants kind of lived resident life minus the cafeteria food. I'm hoping their food was a little better. So what they found was that chronic sleep restriction really also leads to worsening in PVT testing, similar to what we saw in the previous experiment. And as you can see, even after 7 days, the Van Dongen experiment went on for 14 days. So even at 7 days, there is a significant number of lapses with 3-hour restriction group and also the 5-hour restriction group. And again, it declines steadily because they have increased number of lapses. Now, the interest, and this is similar graph. This is number of lapses, and this is also for PVT testing, and it's just looking at their reaction time or the mean speed. And as you can see, as time progressed in the 3-hour restrictive group, the speed or reaction times also decreased. So compared to baseline, there was steep decline. And then after 3 days of recovery, here's the interesting part, and new findings from this study is that the performance on the PVT testing after 3 days of rest for 8 hours per night, that performance does not return to baseline. It doesn't improve to the level it was at prior to the restriction. So in summary, the brain's operational capacity is restricted with sleep restriction and persists for several days, even after normal sleep duration is restored. So recovery is truly delayed, and a weekend of sleep will not help you kind of fill in your sleep depth. So another interesting part here is that the chronic sleep restriction also led to increased sleepiness in the 5 and 3 hour groups. You can see here, this is their baseline sleepiness, and this is number of days. And as the time progressed, the group that was restricted to 3 hours of sleep and also the group that was restricted to 5 hours of sleep, there was an increase in their sleepiness score compared to 7 and 9 hours group. And when they had the recovery sleep for 3 days, their sleepiness score totally went back to what they were prior to experiment. So they normalized to baseline. However, just as a reminder, the speed or reaction time on the PVT testing does not return to baseline. And so to kind of put it in different words, the performance is substandard after recovery and not at baseline. And however, the sleepiness does return. So, even though the participants thought they were adapting, they were not. The brains were saying we're fine, but the PVT performance feel active sleepiness skills with the chronic sleep restriction after enough nights of not sleeping enough, and that can be as low as just 6 hours, the performance still drops significantly, but people feel fine. And then with chronic sleep restriction, after a few nights of catch-up sleep, people feel fully recharged, but their brains are still like, wait, still loading, please wait. So, oh, the chat opened up, okay. Now, so let's switch gears. So we saw how sleep deprivation and restriction can affect neurocognitive function, working memory, which are all very necessary for safe and effective practice of medicine. But let's step back even earlier in our medical career, before residency, before clinical schedules, and look at what happens in terms of undergrad medical education in the MS1 and MS2 years. So this was a systemic review and meta-analysis that examined data on sleep and academic performance in medical students using data from about 40 different countries worldwide. And what it demonstrated is that insufficient sleep is the norm. And across studies, medical students consistently reported shorter sleep duration, delayed bedtime, and poor sleep quality compared to age-matched peers. And this, of course, peaked near exam times and things like that. They also demonstrated that poor sleep is significantly associated with lower academic performance, with negative correlation between the two. That was reported to be negative 0.17 to negative 0.22. Now, in, in one of the other interesting things that came out of this study was that most students were actually unaware of minimum recommended sleep time as well in those years. Now, I'm going to progress through our medical career, and we're going to go into MS3 and 4 years. As students start the clinical rotations and progress in their training, starting residencies and things, we know that the stakes are higher, right? The stakes rise dramatically. And the same insufficient sleep that we saw meant lower grades in our MS1, MS2 students now have far more serious consequences for the medical students themselves, for the clinician, whether, resident, fellow, and the patients themselves. So let's take a look at what happens when sleep restriction and sleep deficiency collides with our medical clinical responsibilities. So this was a study we actually did at my institution. This was a cross-sectional study to look at sleep habits among MS3 students, and it was done, they were given a questionnaire at the end of MS3s were given questionnaires at the end of their medicine clerkship at 2 different institutions, part of Rutgers. So Rutgers Robert Wood Johnson Medical School and New Jersey Medical School. And some of the questions we asked, we could have added a questionnaire. We couldn't, we wanted to add a questionnaire, but we couldn't because we didn't want the surveys to be too long that the students may not complete them. So the questions we asked were really average sleep duration, impact of sleep on clinical and educational duties, impact of sleep deprivation on driving, and their present beliefs and knowledge regarding sleep and how their awareness of need for sleep education. And here, what we of the 314 third-year medical students that were invited to participate across both sites, about 222 students completed the survey. That's 70.7% completion rate. And the results were really striking. And what we found was that 64% reported sleeping less than 6 hours per night. Now, I just want to remind you, we just talked about the previous two studies that talked about what happens when you have sleep restriction for less than 6 hours per night. And, there was worsening in PVT testing and amongst other things like working memory. Um, these students, about 83% reported sleep deprivation impacting their clinical duties. And about 2/3 of the students, 67.5%, reported experiencing fatigue or tiredness at least once per week while driving. Very, very dangerous for people on the road, for the students themselves. And I think that's really the scary part in all of this, right? And interestingly, overwhelming majority, about 88%, had never received any formal education on sleep management. So, that there's our opportunity to really start, as experts in sleep medicine, here's our opportunity to start talking to our medical students about sleep. Now, as we progress through the training, this was a study that was done in interns. This was published in NEJM, the Harvard Work Hours Health and Safety Study. It conducted monthly questionnaires in the interns. That were matched to a residency by NRMP and to graduates of US medical school. They asked questions regarding work hours, extended shifts, or shifts that are greater than 24 hours, motor vehicle crashes, near misses, etc. And 80% completed the baseline survey, and then there were about 1,500 surveys completed each month subsequently. So for a total of about 20,000 survey results. And the results were kind of sobering, and the interns were 2.3 times more likely to crash their car after an extended shift and almost 6 times more likely to have a near miss. Every extra long shift per month bumped the crash risk by another 16%, and those with 5 or more extended shifts per month had double the risk for post-call accidents. So the takeaway is that, sleep-deprived doctors don't just make more medical errors, they are also dangerous commuters, right? And I was just talking to Dr. Thapa about this prior to this grand rounds, that I personally have fallen asleep driving home after an extended shift where there was a fender bender. I hit the car in front of me because I fell asleep. And this happens a lot more than we'd like to admit. So this study really reframed duty hour reform as not just patient safety issue, but a doctor safety issue as well, right? And so just so you know, if you've nodded off at a red light post call, you're not alone. And a lot of us have done it. So another study, this was study done in 2006 by Ayaz and colleague from the same group, Harvard Work Hours Group, and they looked at what happens in terms of percutaneous injuries. Here they followed more than 2,700 interns nationwide and found that the working extended shifts of 24 hours or more was again linked to increased odds of needle stick or sharps injury, odds ratio being 1.61. And these were self-reported just as an awareness. And this also, the injuries were more frequent during the nighttime than during the daytime with odds ratio of 2.04. And this kind of reinforces what we've seen previously, that after prolonged wakefulness, fine motor skills, attention, and situational awareness are all degraded. And in medicine, it doesn't just mean that we're going to have slower thinking, we're going to be foggy. It can also mean needle stick injury to yourself or contaminant exposure or something worse. So it's really, important to keep that in mind as well. This was also another study that was done by Landrigan and team, looking at whether adjusting the intern schedule could actually reduce medical errors. So they randomized interns here to the old school schedule or traditional schedule where they had greater than 24-hour call every third night, versus a reform schedule where the interns did not work any extended shifts. So no shifts that were greater than 17 hours. They also averaged about 65 work hours each week and over 2,200 patient days. And like really looking at real-time error surveillance, they measured the serious medical errors, really harmful ones. And what they found was that besides having 6 less hours of sleep each week and twice the number of attention failures in this traditional group, and they looked at attention failures with EEG evidence of like severe drowsiness. And these interns made 35.9% more serious medical errors. And non intercepted errors were more than double in this group. And the diagnostic errors were 5.6 times more common under this traditional old system. So shows that there is also a patient safety issue when interns were working longer shifts. Now, this was another study that actually looked at what happens to surgeons' dexterity with sleep deprivation. And this was a study where surgeons completed standardized laparoscopic stimulator tasks under 3 different conditions after a normal night's sleep, where they had a sham call, and that's labeled as control here, the first graph in each of these, the first bar graph in each of these graphs. And then there was an on-call night where they were disturbed at scheduled times of midnight, 3 a.m., 6 a.m., and then they performed a task in the morning. And then the third group was where it was a call night, but they really had no sleep at all. And the assessment consisted of doing 20 repetitions of the task in the evening, the night prior to this sham call or actual simulated call, and an identical task the following morning around 8 or 9 in the morning. And as you can see, the results were clear, right? With no sleep, the number of errors went up, the task took longer, and also the stress levels were higher. The arousal score was much lower in the no sleep group. And surgeons that were awake all night made 20% more errors, took 14% longer to complete the task than those who had a full night's sleep. So, in short, the surgeons were slower, sloppier, more stressed, kind of not exactly what you want when someone's standing over you with a sharp instrument, right? Like operating. So, that's also very important to keep in mind that, no sleep makes the hands less steady when doing procedures. So, now let's kind of put this really into perspective. So, um, studies have shown that the longer we stay awake, the worse our cognitive psychomotor performance is, and it declines similar and declines in a way identical or similar to in a way when someone is drinking alcohol. So here, these are 2 graphs. This is relative performance, kind of like PVD testing, right? And this is hours of wakefulness, and this is actual blood alcohol concentration. This study was published in Nature a while ago, but I think it's really, really amazing findings and striking and eye-opening findings. So between about 10 to 26 hours awake, our performance drops roughly the same amount as if our blood alcohol concentration is increasing by 0.004% per hour. And by the time we've been awake for 17 hours, right here, our performance or reaction time and decision making look similar to someone who has blood alcohol concentration of about 0.5. 0.05, sorry, not 0.5, 0.05%. And that's really the threshold for legal impairment in a lot of countries. The places in Europe, like Belgium, Denmark, Finland, Australia, which is not in Europe, but one of the other countries. And you push those limits to 24 hours, and the performance is at the level of 0.1% of blood alcohol concentration, and that's well over legal limit for DUI in a lot of states, including Connecticut, which is 0.08%. And if you keep going, if you keep going, that continues to worsen. So after, being awake for 24 hours, one's not just tired, your performance is like that of somebody who's legally drunk in many of the states. And the moral of the story is that, you know, staying up all night and kind of holding a badge of honor that I stayed up all night doesn't make you a hero, but it really makes you probably the most sober drunk person. So be mindful of that as well. So let's summarize a lot of the studies we discussed. More shifts mean more snoozes. The more extended shift and intern pulls, the more likely they are to fall asleep behind the wheel. Needles don't discriminate. Percutaneous injuries spike after extended shifts. And when you're awake for that long, you can't even trust your own motor skills, right? Errors everywhere. So house staff working extended shifts make more serious medical errors, diagnostic errors as well. Fine motor skills are not so fine after you've been awake for such a long time, demonstrated by the study showing that surgeons took longer to finish a task and made more errors. And really, tired just means tipsy. And after 24 hours awake, your performance is about the same as someone who has blood alcohol concentration of 0.1%. So you're not just tired, you're legally drunk. So a lot of data there. We have tons of data showing us all this, right? So I'm going to start with this quote here. It's really about creating a climate where we acknowledge fatigue. And that also kind of helps to destigmatize talking about it because a lot of us have been there. We're still going through it together. And training, medical training is grueling. And how can we make it safe for everybody? So these are some of the tips and tricks I talk to my trainees about. And they're very like practical things. And a lot of this stuff is found kind of everywhere. So just bear with me. So what I tell them about improving sleep during the day on their night shift rotation is that really have a regular sleep schedule. Stick to your sleep schedule on your night that's off. Oftentimes, residents are doing, six nights and a day off, and then they continue those 6 nights. So that one day off, you really want to try to stick to that night schedule. So you're not going back and forth. You're really minimizing discrepancies in your sleep timing. The other thing I do tell my trainees is that if you know you're starting a night rotation, start trying to acclimatize to that, going to sleep a little bit later on the weekend prior so that you are more used to it when you start those. And I emphasize sleep environment is super, super important. Dark, quiet bedroom, blackout shades help, blackout eye mask helps. Um, I don't have specific things I recommend, but I tell them that it's available readily, that can be delivered to them in our Amazon culture, on the same day sometimes. Cool room is important, quiet room, and sometimes that can be very difficult because you're trying to fall asleep when the rest of the world is getting their tasks done and is awake. So using things like earplugs or white noise machine can also help. And then really, limiting light exposure before bedtime. So using sunglasses when driving home so that you're not so awake when you get home, using the night mode for a lot of these devices so that you're filtering out the blue lights, which can be a trigger to, being awake, and really trying to avoid electronics prior to going to bed. And just as a reminder, everybody often forgets that bed really should be for sleep only because you're trying to create that association between bed and sleeping. So really avoiding working, studying, eating, watching television in bed. It really, again, should be for sleep only. And having that wind down routine that kind of triggers your body that, okay, it's bedtime, having some relaxation time or decompression time, reading a book, calming music, taking a bath, whatever helps. And this is a kind of like a cheat sheet I found. From this group that was published in Frontiers of Neurology. And this is a diagram, again, like a cheat sheet for night shift survival. It's circadian version of like Mission Impossible. You're on night shift, your body wants to sleep, but you're supposed to be saving lives. So you have to manipulate things like a secret agent. So you blast yourself with really bright light when you are on that night shift, in the middle of your night shift. You can try to kind of put in naps in there during your breaks if you like. And then after that, when you leave the hospital, whether it's whatever shift is from, you want to wear your sunglasses. That was labeled in there as G. You're leaving like a celebrity, hiding, and then when you get home, you want to try to sleep in that total darkness as much as you can. Sometimes your neighbors might not cooperate. They may think it's a great day for a leaf blower or like mowing the lawn. So that's when your earplugs or white noise machine may come in handy. And then exposing yourself to light systematically so that you're really trying to shift your schedule and are able to function at night and sleep during the day. Now, speaking of function at night, how do you improve wakefulness on those night shift rotations? So strategic caffeine intake is super important. And the goal here is to really promote wakefulness at night without it interfering with your daytime sleepiness, right? And the caffeine intake, it can be at around your nadir right here when your circadian rhythm is very low, can take 100 to 2 milligrams, 200 milligrams of caffeine, but you really want to try to avoid caffeine about 3 to 4 hours prior to your intended sleep time. And this is data that shows that caffeine really does help. So this figure is from 2010 Cochrane review on caffeine as a countermeasure for fatigue in shift workers. And each block here kind of represents a different cognitive domain, such as reasoning, memory, attention, perception, and then verbal functioning or skills. And it's comparing caffeine to placebo. And this side of the line favors caffeine, and this side of the line favors placebo. And you'll notice that most of the diamonds at the bottom are shifted towards left, towards the caffeine. And so what they found was that there was biggest improvements in memory and attention. um, pretty much what you need when you're trying to read that EKG in your ICU or chest X-ray at 3 o'clock in the morning after, covering all these other cross coverage calls. But the other thing that did not improve was actually verbal functioning and language skills. It kind of stays right on the middle, didn't really change much. So, caffeine might not make you more eloquent and may still give you verbal diarrhea in the morning rounds, but at least you'll remember what you were saying and you will be embarrassed about it later. So again, it can help in night shift performance when you're trying to kind of sharpen your memory and attention skills. And then naps are also very helpful. Short naps, about 15 to 20 minutes during those break. You can often tell the trainees to see if they can cross cover each other to take those naps. They really shouldn't be working if they're that sleepy. And a short nap is helpful because it avoids the delta sleep, deep sleep. And if they're very sleepy, they're supposed to be driving home. They can take a nap prior to driving home. And the reason for that is that if you remember, if you don't sleep and keep going with sleep deprivation, your process or sleep drive continues to increase. And whenever you do sleep or take a nap, that sleep drive would decrease and overall would decrease your sleep drive. So um, help you stay awake during those drive homes or when you need to function at night. And the best thing really is caffeine naps. So what I've been telling residents is you know, drink caffeine and chase it with a nap. And this is what was shown in this 2006 study where they did both lab and field experiments actually to show how naps, caffeine, or the combination of the two affect alertness and performance on night shift. And this was PBT testing again with number of laps on the y-axis, and this is different nights. And the closed in squares, rectangles represent the group that was given that had a nap and also used caffeine. And as you can see, caffeine and nap by themselves were also very helpful. They also improved performance, but really the best was the combination of the two where they had nap and caffeine. It really won the race in terms of sustained attention, alertness, and performance. So it's that can really be helpful on those night shifts. So if you're pulling like a night call, both of these things, moderate caffeine dose, and I think in the study they used about 4 milligrams per kilogram, 30 minutes prior to the night shift, and short nap can be helpful. It won't really, get rid of your fatigue. It doesn't replace sleep, but it really helps you survive that night and function. Some of the things that don't help are, especially when driving home, that I have seen trainees use are things like loud music, talking on the phone, rolling down the window, chewing gum, or even drinking caffeine while driving. Like that's the worst because now you're going to get home and the trainee is going to be so awake from that caffeine that they won't be able to sleep. So really want to kind of counsel them on some effective measures that they can use while doing their night shift. So I am going to end with this quote. I've seen the culture change. There were some early adopters and also some early naysayers who say lack of sleep builds character, but the incorporation of science was a way to get over that hurdle. And with that, I will take any questions you may have.
Thank you so much, Aisha, for this wonderful talk on this very important topic, which is, I think, near and dear to most of us who has gone through this grueling residency fellowship. I don't see any question, but one question I had, we've been talking about this for so many years now
Mhm,
since we were residents. And in medicine, like we talked offline,
mhm,
fatigue, working extra hours are so normalized and, it's part of the
mhm.
training. But how can institutions itself, begin to shift this culture, without compromising clinical exposure to residents? And also, besides limiting hours, like what are the other structural changes that, you come across that could show improvement in trainees' well-being?
Yeah, no, absolutely. I mean, I think it's a really tough topic, right? Because you really are trying to balance our training and you really need a certain number of hours, especially if you think of like procedural trainings, right? And how do you balance that with sleep and everything else? I think there are some small changes that can be made, right? Normalizing talking about being tired and fatigue, I think is very important. Having cross coverage amongst trainees, like being comfortable saying, hey, I'm really sleepy. I just need like 10, 15 minutes of nap. Here's my pager. Well, I date myself saying pager, but here's my phone. Can you hold it for 15 minutes? And even as attendings or people who mentor trainees, we should be comfortable talking about this and saying, hey, you look very sleepy today. Do you need a nap? Like go take a nap for 10, 15 minutes and then come back because we know when they come back, they're going to function better as opposed to just kind of going through and of trying to function when they're so tired and fatigued. A lot of institutions have nap pods that they've placed in the hospital or in the library, which I think is great because it really helps to decrease the sleep drive. I think prior to this, we were talking about ride sharing, right? With Uber, Lyft, all of these things available. Really, nobody should be driving so sleepy that they're getting into car accidents after these long shifts. And in 2011, when ACGME changed, I think it was 2011, duty hour restrictions to interns not having calls for 24 hours plus. They actually went back on that, right? They said it was okay to revert back, but a lot of institutions kept that in place, which I think is very important. Thinking about how we function when we've been awake for 17 hours straight. So I think there are some small changes. I think the biggest thing has to be the culture change that comes from us, that people are comfortable mentioning that they're sleepy.
Yeah, pointing out that we were sleepy and we are sleepy still, despite, like,
And I talk about trading, but I think this problem still persists even at attending levels and beyond, right? Because at least there is duty hour restrictions there. For us, we're kind of monitoring ourselves, and a lot of times we work our regular academic jobs, and then on top of that, we'll pick up moonlighting shifts. So there's really, it's difficult to monitor that even more.
right, right. Um, any other questions, or if anyone wants to ask question on their own, please feel free to unmute yourself. I don't see any questions. Well, I think with that, we'll give it 4 minutes of everybody's time.
Yeah.
Thank you so much. This was, excellent. Again, refreshing and, trying to have this duty hour and, the time limit, just being emphasized to everyone, to interns, residents, attendings, because there is a limit. There is data that shows that, there's
Yeah.
a number of hours that human beings can work. So,
I mean, I think for us, just start off with doing these talks for residents and our medical students at GME and stuff to bring attention to these issues and how they're very real and what we can do about it. And also kind of armoring the trainees with a little bit of knowledge. Simple things like when I was driving home, I was drinking coffee as a resident thinking it's going to help me stay awake, but we know it's not true. So it, spreading that knowledge from all of us, I think, will be very helpful.
yeah, very true. Thank you so much. And
All right. Take
you,
care. Thank you so much for this invitation. It was so wonderful. Really
thank you.
appreciate it.
There's a lot of thank you for you. All right.
Thanks.
Thank you, everyone, for
Bye.
listening. Bye-bye. Have a good one.